gentlemen, thank you for standing by, and welcome to today's presentation, Emotional Intelligence in Healthcare, the Human Factor in Supporting Technology Innovation and Care Efficiency. I would now like to turn the conference over to your moderator for today, Wendy Barnum of PerfectServe. Wendy, please go ahead.
Thank you, Nathan. Thanks for covering the housekeeping items. Hello, everyone. We appreciate you joining us on this Tuesday afternoon or morning, depending where you are. PerfectServe is pleased to sponsor today's educational webinar focused on emotional intelligence in healthcare. For those of you who may not be familiar with PerfectServe, PerfectServe is healthcare's only comprehensive and secure communications platform that connects clinicians across the care continuum. More than 35,000 physicians across the country rely on PerfectServe's cloud-based communication system that routes voice, text, web, and system-generated communications. For those of you who regularly join us for our thought leadership webinars, many of our topics focus on strategies and tools that support process improvement. And I'm pleased today to have Dr. Alan Rosenstein with us, and he'll dig into emotional intelligence in healthcare. Dr. Rosenstein is currently a practicing internist in San Francisco, California, medical director for Physician Wellness Services in Minneapolis, Minnesota, and a consultant in healthcare management. Dr. Rosenstein has over 140 nationally recognized publications and has extensive national lecture and consultation experience in care management, clinical decision support, nurse and physician staff relationships, and behaviors affecting patient safety, quality, satisfaction, and clinical outcomes of care. We're very proud to have Dr. Rosenstein with us again today. Thanks for joining us. I'll turn it over to you at this time, Dr. Rosenstein.
Thanks, Wendy, and welcome, everybody. As Wendy said, the topic today is improving emotional intelligence and communication skill sets to enhance positive work relationships and patient care. Now, one of the things I'm going to get into in a little while is how complex healthcare has become over the past few years. And it's really crucial for all of us involved in the healthcare delivery process, whether you're a physician, a nurse, a support person, a frontline person, even the patient and the family, to really understand what everybody's intent is in providing good patient care. And providing good patient care means understanding what you're able to do from a knowledge and technology perspective, but also understanding what the goals and motivations and incentives are of your staff and your colleagues in your work relationships, as well as the patients and their family. So as far as the learning objectives, we'll talk about the advantages of emotional intelligence and its effect on relationship building and communication efficiency. Hopefully we'll get a better understanding of the stresses and pressures in today's healthcare environment, which affects individuals' attitudes and their behaviors that impact healthcare relationships and eventually downstream clinical performance. We'll learn how to improve provider engagement, compliance, communication, and collaboration by initiating programs that enhance emotional intelligence and addressing other underlying cultural, generational, hierarchical, and historical barriers that affect values, attitudes, and behaviors. And then we'll finish up by talking about the advantages and disadvantages of technology and how they impact communication efficiency. So let me start out just by defining what emotional intelligence is. Emotional intelligence has been around a long time. It goes through the psychological literature, the anthropological literature, the humanities literature, and is now slowly working its way into becoming a very important topic in healthcare. And basically what it is the ability to perceive, evaluate, understand, and be able to respond to individuals and influence their emotions. Other terms that are used are social intelligence, mindfulness, and empathy. What we look at is it's really a four-step process. The first step process is self-awareness, understanding who you are, how you react to different situations, what your values, what your own individual biases are. And then moving to the upper right, social awareness is understanding the person you're in contact with, whether it's a colleague, whether it's a staff member, whether it's a work person, a relative, or a patient, understanding what's going through their mind, what are their values, what are their needs, what are their priorities. And then it's self-management. So part of self-management is understanding what you're all about, understanding what your contact is all about, and then being able to manage a conversation to get to a mutually beneficial goal that meets your needs and the individual needs. And in the end, it really ends up in having a very strong relationship and under relationship management. Now, what I put in here is some interferences. In an ideal world, everything goes according to plan, but there's internal interference and there's also external interference. And if you want to make that communication and emotional intelligence process work well, you really need to understand how to deal effectively with those interferences. So I look at emotional intelligence doesn't stand out there by itself. It's really a combination of this pie. So we talk about what emotional intelligence is, but it needs to be backed up by good communication skills training. It needs to be backed up by supporting technology, whether it's electronic medical record or smartphone or database analytics. You need to understand how to manage stress and anger. You need to understand how to manage conflict. All of this is involved is improving your relationship management. In some cases, it will require behavioral modification. But at the very core, what we're also looking at is what's going on in the organization. Now, you may have individuals who don't behave professionally or poor communicators, and yes, the individuals need to be dealt with, but you really need to understand what's going on in the organization and have a very positive supporting culture. I just want to start out a little bit talking about what Malcolm Gladwell has to say. I mean, I am a practicing physician, and I look at physicians as being a very precious resource. Actually, I look at all healthcare providers as a precious resource. We're all just trying to do our job. But with the changes in the environment and the changing expectations, I think our idealism is being affected, and we can't lose sight of who we are, and we need to better deal with these pressures. So to read what Malcolm would say, he'd say, most physicians go into medicine with a mission-driven spirit committed to helping people. They are grateful for the opportunity to care for others. They're proud of their ability to diagnose and treat, and they're inspired by the trust their patients put in them. But those experiences contrast vividly with the economic side of being a physician. Each day, mundane financial tasks distance doctors from the reasons they chose medicine as a career in the first place. That's the duality of being a doctor. There's a fulfilling personal side and the frustrating impersonal side. The personal side reminds doctors why they love practicing medicine. The impersonal side poses a significant threat to the future of medicine. So if we just think back what the image of doctors have been, and now in my generation I was brought, and for those of you who are looking at the slide, if you can just try to figure out who all those individuals are. If we were an interactive session, I would actually ask you to give me your answers. But when I started out in my life and brought up in television in the 1950s and 60s, we have Dr. Kildare, we have Dr. Welby, and we have Dr. Ben Casey. They were all these doctors. They loved what they were doing. They would accept chickens in payment. They go on house calls. They really had a friendly, cordial relationship with their patients, and they were loved by all. And then we moved into the healthcare genre starting in the 1970s and 80s, and we get a little bit more edgy in what the perspective is of doctors and hospitals. You have St. Elsewhere, you have ER, and then on the very bottom right, you have Doogie Howser. And then you move more into the 1900s and the early 2000s, and here the image of doctors and nurses is getting a little more edgy when you start looking at Grey's Anatomy and some of the other programs that are of that genre, including Scrubs. And then you move into 2014, and you get the soap opera General Hospital, which is still on the air. But then you get the real edgy type of physician. You get House, and you get the edgy type of nurse from Nurse Jackie. And that's now some of the image that's going on with some of our patients or what they think about their interactions are with doctors. In the lower right corner is my picture when I was doing my residency in San Francisco. So I had done a lot of research while I was working at VHA, and I'll share some of that research with you on disruptive behaviors in physicians, nurses, and others. And I remember being interviewed, this is December of 2008 from the New York Times, where they were trying to have an expose on an arrogant, abusive, and disruptive doctor. And it became very frustrating because that's the image, it's sort of sensationalism, trying to get this edgy type of stuff and having the image of doctors falling under this category, and I really took issue with that particular concern. So when we look at behaviors, what we really want is a whole spectrum of behaviors, On the top, we really want somebody who's fully engaged, they're collaborative, they're the champions. They'll do everything that needs to be done to try to get the best end result, which is good patient care. Those are the prototypes. Those are the champions. The more you have of those, the better your successful program will be. Then down the scale, you have the engaged and participative physician or nurse or team member. They're not the real advocate. They'll just do what they were told, but they're certainly not a negative influence on the force. And then you move down the spectrum of behaviors to somebody who's non-compliant. They just don't do what you want them to do. They don't follow the protocols. They don't wash their hands. They don't chart. They don't make themselves available. They don't respond to phone calls. They're generally poor communicators. And then you move down the line on the adverse side of behaviors into the passive-aggressive. The passive-aggressive individuals are typically the ones who just, on the surface, everything is fine, but they'll do sabotage underneath. And, not to stereotype, this is more of a disruptive behavior in the nursing sector, and it's actually been termed a horizontal hostility. And then you move into the frankly disruptive behavior, which can lead to destructive behavior, and that's the prototype that's been given to the physician. But the concept is that it's very it's during the acute course of action. It's usually short-term and no malintent, but they don't realize what kind of impact it's had on the individual and eventually the downstream impact on patient care. So we started doing the research, and we published this over and over again in multiple different specialty journals. What we found is 3 to 5% of the physician and nursing staff are truly disruptive, but we also found that 40 to 60% of them are ineffective communicators. On the top graph on the left, when we did our survey, and our survey included 10,000 respondents from probably about 350 hospitals across the country, we asked them to rank their responses if they saw a disruptive event. Was it linked to any undesirable behavioral factors? And we asked them to rank it never, occasionally, sometimes, frequent, and constant, and that's the ones we put in the graph. So think about this. When you're involved in a disruptive event, 95% of the people feel stressed, they feel frustrated, they lose their ability to concentrate, communication is impaired, information transfer is impaired, and there's reduced overall collaboration. And then when we asked, are there any potential adverse effects, 2/3 of them said, yeah, adverse events occur. 71% said medical errors occurred, compromises in safety, compromises in quality, and even in some cases it led to preventable mortality. So in order to understand what makes individuals behave the way they do, we really need to go to some of the forces that shape their being. So from the internal forces, some of these are genetic, some of these are just inborn. It's age and generation, gender, culture and ethnicity, and life experiences. And these help to shape a person's personality. And again, not to stereotype, but physicians who are very competitive in nature with a very strong superego, they become more dictatorial, they're more narcissistic, they can become desensitized, and as a byproduct of that, they have low emotional intelligence, and that's what we're going to talk about in a minute. And then you have all the external forces going through the training program, the healthcare environment, the work environment, and then we're really impacting individuals' behavioral and emotional health, whether or not they get stressed, fatigued, burnout, frustrated, angered, move into substance abuse, and even a much higher incidence of suicidal ideation. So all of these things need to be considered when you're trying to deal with somebody to improve their communication skills and emotional intelligence skills. You really do need to think about the predilection for their individual biases, values, and attitudes based on age and generation. The younger generation or the older generation, the baby boomers and the veterans, they'll stay at a job forever. They're very task-oriented. They'll work until the job is done, whereas the younger generation is more work-life balance. I'll do it, but it's 5 o'clock. I'll come back to it tomorrow. It can wait. And it's not that any of these values are right or wrong. It's just when you have this mixture in the workforce, you need to understand other individuals' values in order to get a compromise in getting what the task accomplished. Gender differences, men are very task-oriented, very power-oriented. Women typically are more social conscious. They're processing multiple things at one time, and they'll talk about things with their colleagues. culture and ethnicity, issues around gender, issues around power and authority, issues about the willingness to speak up or to be very reserved. And again, all this shapes the different types of personalities. So those are all the internal factors that influence the way people behave. We need to know about those and work with those, but those are the ones that are more ingrained. But the external factors, these are the ones that are more short-term and may have be more amenable to as an opportunity for improvement. And one of the things that's coming out now in the medical schools is the type of training. It's basically a rites of passage. You go into medical school, you have very low self-esteem. It's a very competitive process. In order to gain knowledge and technical competency, you work independently. It's the antithesis of working with teams and personal skills because you're independently trying to seek knowledge and technical expertise, but there's no training in personal skills or team collaboration. Luckily, most of the major societies like the Robert Wood Johnson Foundation and the AMA, they've recognized that we need to change the medical school curriculum, and there's now millions of dollars in grants in helping these institutions change the way the students are trained, putting more time into development of personal skills and empathy skills and teaching emotional intelligence. The external factors for physicians who have been in practice for 10 or 15 years, healthcare reform, greater accountability, adherence to certain performance metrics, increasing complexity, and now with the rampant technology implemented both in medical records and smartphones and connecting all the dots, it's changing the healthcare environment. It's putting a lot of pressure and stress on the individual physician. And we had done a lot of research as others talking about the impact of stress and burnout. And if you just look at the slide, you can see by physicians generically or by specialty, 50% of them report being stressed. Majority of them report being burned out. And this can have significant impact on their career and whether or not they want to continue in medicine. So what you wind up is with physicians who are frustrated and angered, it affects their behaviors and it may affect their clinical performance. And it's not just physicians. Nurses are under stress. There's a term called compassion fatigue. A lot of it has to do with changing roles and responsibilities, changing work schedules, spending more time on non-clinical duties. Administrators are under stress with the changing models of care and the emphasis on financial incentives. And certainly the patients and the family are under stress given the complexity and the issues that they have to deal with and worried about insurance coverage. So what's the staff and organizational impact? What we're finding through all these forces, physicians are less happy, nurses are less happy, there's greater feelings of irritability, cynicism, apathy, sleep disturbances, fatigue, negative impacts on their physical health, and negative impacts on their emotional health, and eventually that can translate into performance liability and concerns about patient safety and satisfaction. The organization is worried about culture and morale. They're worried about increased turnover, the ability to recruit and retain. They're worried about poor coordination and productivity. They're worried about compliance with best practice protocols. There's a greater incidence of disruptive behaviors, non-professional behaviors, and non-communicative behaviors, which can impact patient safety, patient satisfaction, and eventually be a source of financial liability. So that's the background information. So what do we as individuals and colleagues and as organizations really need to do? Well, we need to make sure that we understand what's going on and make sure the individuals who are working as part of the organization become aware of what's going on so they'll get motivated to make some changes. Another part of it is to assess organizational culture and then provide staff support, offer education and training, teach communication and collaboration skills, have the right policies and procedures for what appropriate behavior is and what inappropriate behavior is, and the ramifications of what individuals will face if they don't follow appropriate behavior standards. How do you report inappropriate behaviors? How do you intervene? And it's all about reinforcing patient safety and enhancing job satisfaction. And we're going to go through each of those points in the next few slides. So recognition and awareness. The whole idea is to get an understanding and the intent. We want all members of the healthcare team to recognize that they are interacting with colleagues and staff, patients and family, and we really need to take their sensitivities into consideration when we're addressing them to make sure they understand what's going on, and also to make sure that everyone's in agreement as to what the right treatment course might be. And when your behaviors are not able to reach that means, then we want to talk about how we can motivate you and actually teach you to become more compliant and more sensitive. And part of it is getting people to realize why would I want to do that? So you really need to let them know these types of behaviors can affect how you're feeling, how the staff is feeling, how the patients are feeling as far as the satisfaction of services delivered. It certainly has a big impact on employee morale and energy. It'll have an impact on employee retention, care coordination, and performance efficiency. So the whole idea is you bring people back to their core values of what's important to them and why they went into this particular individual profession. The second thing is really looking at organizational culture. The importance of organizational culture is a separate session by its own. But by definition, organizational culture is just a summary of all the attitudes, values, and behaviors of individuals working at the organization. So it includes board imperatives, it includes administrative and clinical leadership, it includes frontline staff, it includes everyone else who's involved in the healthcare process. How do they act? What are their responsibilities? How's the overall morale? And if you would do a survey or a self-assessment, you really can get a finger on the pulse, and that gives you an opportunity to implement programs that will improve attitudes, improve culture, and overall improve clinical performance. So the key pieces of that are doing a survey, having the right structure and process in place, focusing on the input of the survey to develop programs that will improve overall relationship management. Staff support. As I alluded to earlier, there's a lot of frustration out there, a lot of changes in healthcare, more complexity. So we need to recognize that this is putting increasing pressure, stress, frustration, apathy on our healthcare staff, and we really need to try to work with them to help them better adjust to their environment. So the whole idea is we need to recognize that this is a significant issue, and we also needed to bring it to their attention. The part of be responsive is when medical staff or nursing staff or employee staff are talking about certain things in the organization where they have a concern, you really need to listen to what they have to say and be responsive to their needs and try to implement something that will produce a better outcome. As far as prevention, one of the things we were doing at the hospital was an onboarding process. When new physicians would apply to the staff, I would sit down with them and welcome them to the staff, talk to them about what their expectations, and then I would really talk to them about the culture of the organization. We have an electronic medical record here. Our focus is on effective care management and discharge planning. We're working closely with the community to try to prevent hospital readmissions. So the idea is get them sensitized to what the expectations are and have a give and take conversation so they feel like they are a good cultural fit for the organization. Prevention also would include education and training. I'm going to talk about that in a minute. Raise awareness, solicit input, address concerns, and establish mutual goals. And then when you find that the staff is really suffering from a lack of ability to adapt, then you might provide certain support services. Yes, what we'll do is we'll get a nurse practitioner or a physician assistant to help you. Yes, we'll get you some help to help you with complete your medical records. No, we won't schedule for back-to-back committee meetings 4 days in a row. And then when some of the individuals get involved more in behavioral problems, the organization can provide behavioral support. Sometimes it's just informal discussions. Sometimes you can provide support through wellness committees. In some cases, you might recommend coaching or counseling. Some organizations have used the Physician Employee Assistance Program. And if the behavioral disturbances are more intense, then you're going to do more specific behavioral modification. Education and training. General education, somewhat similar to what we're going through right now. This is the state of affairs. This is how people are being impacted. We look at all of you as being a precious resource. We want to, one, make you aware of what's going on in the environment, but at the same time, we want to help you better comply and adjust. So you can have structured education. You can talk about phone etiquette, charm school, assertiveness trainings. language support, time management, stress management, conflict management, anger management, emotional intelligence or sensitivity training, diversity training, cultural competency, and communication and team collaboration skills training. That's all the types of services you can offer to your clientele, and we're going to go into a little more detail. Improving communication efficiency. This is probably the nuts and bolts that we have to do, particularly now because of the complexities in the healthcare environment. And I'll just refer you to an article that I wrote in a couple of years ago. It came out in the Physician Executive Journal, and it's called Physician Communication and Care Management, the Good, the Bad, and the Ugly. When you think about physician communication, one thing is they need to communicate with other physicians. In the hospital setting and also in the outpatient setting, you've got 5 different physicians treating a patient. You've got the surgeon, you've got the infectious disease specialist, you've got the neurologist, you have the cancer specialist, you have the internist, you may have a hospitalist, and each one of them may have a different idea of what's best for the patient and go to the patient with a different treatment plan with different potential outcomes. Well, we really need physicians to coordinate their plans, so we need physicians to better talk to each other, and it really brings back to the importance of the captain of the ship. Someone needs to assimilate all the different opinions between the different physicians and present a unified front. So physician-to-physician communication is key, physician to staff, physician to the case manager, physician to the nurse, physician to the physical therapist, physician to the respiratory therapist. Again, with all the complexities in healthcare, the better the communication between the physician and the staff, the better the understanding of what the appropriate care is for the patient, and the better presentation of expectations to the patients so they won't be frustrated. And then you carry it down the line, staff to staff, and physician to staff and patient and family. On one area, it's about setting the treatment plans and the expectations. The other part of it is talking about issues related to palliative care and terminal care and giving them an opportunity to understand the cost-benefit and then coming out with a treatment plan that satisfies your needs and their needs based on their values and wants. What are the communication liabilities? As I said, in medical school in particular, you're trained on technical competency and knowledge competency. You have a very autocratic, bureaucratic, domineering type of personality. I mean, a physician gives orders. There's no real exposure to emotional intelligence. And then in the next slide, I'll talk about the pluses and the minuses of new technologies. So what are the communication prerequisites? Well, mindfulness is just having a greater appreciation about how you're perceived and trying to have some perception of what the wants and needs are of the individual that you're talking to, again, whether it's staff, patient, or family. You need to be engaged. You need to exhibit certain skill sets. You need to take the time. You need to have the right body posturing. You need to show interest. You need to avoid distraction. You need to be responsive, and you need to make sure people understand and clarify what their takeaways are from the discussion. What are the communication barriers? Well, as I said, historically, demographics, culture and ethnicity, gender, they all can influence the way that people communicate with each other, and eventually it all rolls up into an individual's personality. Training, the hierarchy of the healthcare system, the environment, growing frustration, dissatisfaction, stress and burnout, lack of awareness and sensitivity, denial and resistance to change. I've been doing this for 20 years. Why do I need to do something differently? The physician's attitude, and again, I'm really talking stereotypically, is really command and control. You know, they're in control, and they don't really want to listen to others. A lot of physicians, particularly when you get the specialist in, they're focused on the organ. I'm a kidney doctor. I'm here to treat the BUN creatinine and the proteinuria, and they sort of lose perspective of what the whole disease is, or certainly have no perspective of the full patient's needs. And then physicians are under a very demanding schedule. They have the time to do this. They make communication a priority. And do you have training in how to handle a difficult conversation? And then we get into the issue of segmented care. And this, again, when we're going to talk about technology advantages, you've got the patient being treated in the emergency room who's communicating with the on-call attending. The patient's going to get admitted to the hospital. They're going to have a consultant managed by a hospitalist. Then they're going to go home to a primary care MD. Each of these individuals may be focused on their particular segment of care, but someone needs to focus on the entire spectrum of care, and this eventually what leads to what population health is, and this is where technology can certainly be a blessing. Also, we need to worry about how efficient our process and information flow is, and then we're going to move into the technology advantage. So what's the advantage of technology? It provides you with very timely information. It has access to multiple data banks, so it can assimilate information. It can disseminate the information to all those who really need to have it. Certainly will cover the full spectrum of care, so it's not just the hospital information system, it's not just the emergency room information system, it's not just the laboratory system. When you get all this information, you can do appropriate analytics. One is you can report on performance metrics, and you can also do opportunity analysis, what type of population you have, what type of needs they have, what type of interventions do you really need to bring forward to keep everybody healthy or to get timely care. Electronic systems can have immediate access to results. It can provide you with alerts and reminders. It can hold people accountability by shooting out a message. Say, Dr. So-and-so has found this, please follow up. And certainly it can provide overall monitoring and surveillance. Those are excellent opportunities, particularly in today's healthcare environment. But I want you to consider the technology disadvantage. There's lots of articles on errors that occur with the electronic health record, and that's not the issue I really want to talk about. The real issues are the adoption curve. Particularly the older physicians, they're going to have a little more frustration in adapting to electronic medical records. We really need to help them move through this type of process. We do have to worry about errors, and we need to get the errors out of the system. But my main concern is what I'll put down here is no empathy. We can have electronic messaging. We can have lean design. We can have best practice protocols. We can have your compliance report. But all of that is data. We still need to have the process to have person-to-person interaction, because a lot of what goes on, particularly in compliance, is really due with relationships. If you look at why patients fail and get readmitted, a lot of it is their understanding of what they really need to do. So I think technology is a fabulous product to get everything going, but I think we really need to continue to work on the importance of personal relationships in healthcare management. So to do that, you would consider doing communication skills training. There's lots of different courses out there. There's a scripting tool, which is the SBAR tool, which was designed to get a nurse to efficiently interact with a physician. In 1 minute, give us a situation of the patient, the background, your assessment and recommendation. Quinstuder has something for a nursing checklist and a script. Assertiveness training, this could be offered by Crucial Conversations or others. It's the importance is speaking up when you have an important question, and certainly if you're worried about something potentially bad happening to the patient. Then when you get people who are frustrated or angry or stressed, provide the appropriate courses to help address these issues, to prevent these issues from impeding their communication. And then there's a whole cadre of different basic communication skills. The idea is to sit down with somebody, to introduce yourself, tell them who you are, acknowledge who they are, engage them, show them that you're willing to devote the time, you're attentive, you don't want to look at your computer, you don't want to continue to respond to voicemails. Your body tone and your posture is actually more important in the patient's eyes or the staff eyes than what you're actually saying. Try to avoid conflicting or confrontational situations. Reflective listening. Sit and listen and don't interrupt, and then hear what they say and then respond appropriately. Show empathy. Make it comfortable for the individual so that they have their trust in you. It's a safe environment, and really take the time to set the expectations and to talk about appropriate follow-up. So communication skills at that level is usually a one-on-one. When you get into the team collaboration skills, and I know HatianStream has had programs on this before, it's how as a group we all need to act together. So this would be a surgical group, an OB group, an ICU group, an emergency department group. When you're working together, understand what everybody's roles are and be willing to assist them in their needs. Build trust, respect, and commitment. reinforce accountability and task responsibilities, speak up when you see things going awry or potentially going awry, make sure you're managing the patient according to best practice protocols, be willing to discuss everything either before or afterwards, try to avoid conflict or confusion, overall enhance communication, and never forget to thank people for a job well done. And then we move into so you've got the scripts for good communication, you've got the script for good team collaboration, but it's really one step deeper, and that's the issue about emotional intelligence. And I guess just to reiterate, are you aware and sensitive to other people's values and priorities? And many times you're so focused on what you're doing, or you've never taught that skill or the importance of that skill. It is a crucial skill if you want to get the best impact for your time and effort. We need to reintroduce the word empathy. It's not that we're not all empathetic. It's just all the distractions get in the way. And empathy is really the ability to perceive, control, and evaluate emotions, be conscious of, and have compassion of your audience. And some people will call that mindful practice. Understand the benefits. The benefits is the patients will understand, the staff will understand, the task will get accomplished, it'll be a job well done. And the requirements are what we talked about before. You need to be receptive, you need to do some self-inquiry, you need to be open to new perspectives, you need to be able to read the signs and adjust your behaviors accordingly. So here are the caveats: receptivity and motivation. Why do people want to change? So what you really need to do is you need to link to their core values. And those in the healthcare profession, what do they want to do? They want to get the best possible patient outcome from a quality perspective, from an efficiency perspective, and a satisfaction perspective. So this can be gained by improving relationships, which revolves around improved communication and collaboration. The tasks get completed. There's no communication gaps. People now understand why it's important to be compliant or get the tools to reinforce compliance. If we improve overall care efficiency, we'll get lower error rates and improved outcomes. We'll improve productivity because there'll be less waste, less disruption, greater focus on task. And overall, everybody will feel happier and satisfied that they've done the right thing, people understand, and you reduce the associated stress and frustration in working through the process. So what is the actual training? Well, there's not one real prototype. Part of it is developing people skills, which is basically behavioral modification. Some people will put you through service excellence, customer satisfaction, diversity training, conflict management, anger management, or specific communication training, which really talks about the issues we talked about before, being thoughtful of what you're doing, being empathetic, and controlling your reactions to get the best possible outcome. So what are the barriers? Well, I'm a physician. I'm really, really busy. I'm struggling just to do the electronic medical record. It sounds great, but I really have no interest in it. And then it says, well, I guess it's really important, but I don't really have the time. I've got a very demanding schedule. And, it's good, but, I'm not sure it's really necessary. And I'm focused. My job is I have to treat the patient. I have to see everybody, one patient new every 15 minutes. I have to make sure that they're getting their hemoglobin A1C checked. I have to make sure that they understand their discharge instructions. And then, I'm following best practice guidelines. I've been through Lean. I've been through guideline training. But as I said before, one of the problems is that's not really empathy-based. I don't have the capability. Logistically, this doesn't work for me. Underneath the scenes, I'm really angry. I'm frustrated. I'm sort of burned out. I don't need all of this stuff. There's organizational issues. There's issues with relationships between the administrators, the clinical people, the nurses. I have some underlying behavioral problems. I'm under stress, but, I can take care of it myself. And, I've got this routine, and I don't want anybody else telling me why my routine is no better, because show me the money. There's nothing that I've done that's wrong. Those are all the potential barriers. So you need to get through those barriers. You need to have programs on not only communication skills, but also conflict management. Again, this is a full discussion by itself. It's really understanding that there are high conflict personalities, and you need to deal with those high conflict personalities in a way where you recognize what's happening, you get a skill set to diffuse the situation and resolve the problem before some harm is done, either to the staff or to the patient. So there's a whole skill set of managing that particular conversation, diffusing it, and getting the individual to reflect on what they're doing and try to come up with a different alternative of how they may better solve the situation to prevent the downstream friction, which can have negative results for all parties. Then the relationship management piece is just a combination of all the things that we had talked about before: emotional intelligence, conflict management, negotiation skills, stress, time, and anger management, sensitivity training, diversity management, cultural competencies, sexual harassment, personanalysis is a way to understand different people's personalities, project management, communication skills, and team building. They all fall into those pieces of the pie. And yeah, you can focus on one or two or three of those different segments, but really, if you have an appreciation of all these different contributing factors, you're going to have a much better outcome in the end. Now, when you do have individuals who are just either disruptive or exhibiting non-professional behaviors, then you really need to do something about it. So when you've gone through the idea of trying to get people to recognize this as an issue, you're talking about providing support and trying to help them out and better adjust to their practice, provide emotional support if they're stressed, frustrated, or anger, really getting them to understand the importance of their attitudes and behaviors and how it impacts those they come in contact with, and particularly the patient. But for some people, if they don't want to follow what you're doing, you need to have recourse. And one of the first issues around recourse is actually define what an appropriate code of behavior is. And of course, this is now a mandate from the Joint Commission that organizations need to have a code of conduct policy and provide some support to make sure that it's happening appropriately. The second thing is you need to report disruptive behaviors or inappropriate behaviors in a consistent fashion. It's not like, well, gee, the head nurse is over there, let me talk to her. Oh, wait, I see the chief of surgery over there, let me talk to him or her. What you really need to do is, if there are truly disruptive events, you really need to have a very consistent process where that particular event is analyzed by a non-biased group, and usually a multidisciplinary group, will look at the event, do the appropriate investigation, and then make the necessary recommendation for follow-up. And I'll talk about what that follow-up will be in a moment. So having the policy and having a consistent reporting process with consistent follow-up is crucial. Then the intervention strategies, when people are just not willing to move forward or are unable to move forward. The best way to intervene is prevention. So one thing is, even before you're hiring somebody, you might want to do a cultural assessment. It is new culturally fit interviews to see, this is what our organization is about. Are these the values that you hold important to your own individual practice? And then you need to raise awareness of how important this is, talk about understanding and emotional intelligence, and providing the appropriate education, training, and assistance. And then what you have is the pre-event early intervention. If you notice that somebody's really, their attitudes have changed, their personalities change, they're a little bit short, they're tense, they're really under stress, then you really do want to try to work with them in a proactive fashion to get to better understand what's going on and to provide the necessary support services. The one thing about physicians, and it may not be unique for physicians, if they're working under stress, either one, they don't recognize it, or two, yeah, they recognize it, but you know what? I've been under stress all my life. I can handle it. Oh, how's that going for you? Well, I guess I could do a little bit better, but there's no way I'm going to open myself up to someone else because you don't know my business because you're not a physician. I'm worried about confidentiality, and if the word ever got out that I talked to you about helping me deal with stress, people are going to think I'm incompetent. So you need to get through all of that resistance and provide the types of services that are convenient for them, that meets their individual needs. And the goal is not to punish somebody, but it's really to help them better adjust to their particular stress or environmental pressure, because we look at you being as a precious resource. So those are all the caveats that you go through, and whether you do that through HR, through your wellness committee, through individual coaching and counseling, or through an employee assistance program, anything that you can do that works is great. In some cases, the behaviors are so bad that you really need to do intense behavioral modification or send individuals away to sites that deal with these types of issues. Having the conversation. When you notice that somebody's not acting the way they should, it's crucial to have a conversation where, one, it's at the right time and place. Two, it's done by an individual who is skilled in whether it's conflict or avoidance or stress management. They really need to understand what the skill set is to wind up with a positive outcome. So what you'll do is you'll go through a conversation. The person doesn't know what they did. When you brought it to say, I didn't mean that. And then the thing is, oh, I didn't know that it would have a downstream effect. So you're slowly getting them through the process where they're trying to rationalize or become defensive. And then you might ask them, well, what do you think you could have done better if it occurs again? So they actually open up, and that's your opportunity to have the conversation. When you have to do intervention, there is Dr. Hickson, who's a good friend of mine from Vanderbilt. He has this 4-step intervention process. The first one is coffee time. What you do is you meet with the individual in a very informal setting. You just about how are things going? I noticed that you were screaming at somebody, and you just have this polite conversation. And a lot of the time, just by raising the level of awareness, people will move to self-correct. In more intense problems or chronic problems, then you really need to go through coaching, counseling, and behavioral modification. And in the very end, if people are just that disruptive and are really negatively impacting staff relationships and patient care, you really need to think about whether or not you're going to sanction or terminate. In the end, this is all done to get best patient care. So all of these programs we're talking about really reinforce patient safety and quality, risk management protocols, infection control, care management, value-based initiatives, accreditation, magnet if you're going to magnet, patient satisfaction, staff satisfaction, compliance with HR protocols, and really right now with the emphasis on readmissions and population health, you're really trying to accomplish best care along the entire integrated network. So finishing up, what are the wants and wishes? What do physicians want? They want good patient care. They want to feel happy about what they're doing, successful and respected. They do want to have work-life balance and control, and sometimes they don't know that their work-life balance is out of whack, so you need to help them. And we're looking for either their organization or their group or their friends or their family to provide support. So let them open up, to talk to them, to provide them, get understanding of what's going on, and then try to provide some process that will help them move forward in the spectrum of improvement. For organizations, they want to, they have their mission. They want a good culture and good morale. They want a strong reputation. They want to be able to recruit and retain. They want less disruption. They want better communication and collaboration. They want to be able to resolve conflicts. And overall, they want to improve all the important metrics, which are quality, safety, and satisfaction, and get everybody on board to feel successful. So the solutions. Recognize increasing complexity, change, and care redesign. It's here whether we like it or not. We need to look at physicians, nurses, and all of our staff as a precious resource. We need to recognize that everybody just wants to do their job, but there are many things that are getting in the way which they don't right now have control over. A lot of individuals are frustrated, they're stressed, they're fatigued, they get too burnt out. They're reluctant to seek outside help. They listen to what they have to say. A lot of times when you're talking to them about how inappropriate they're behaving, and they're saying, well, if you would have had X, Y, and Z, you really need to listen to what that X, Y, and Z is, because usually there's something behind it, and some of them may be organizational-wide rather than individual. You need to provide the appropriate proactive, empathetic, operational, clinical, and behavioral support. You need to motivate them. You need to provide the appropriate tools. Part of those tools are the relationship tools, and part of that is the technology tools. You need to focus on satisfaction, and in the end, recognize and reward for a job well done. So with that, Wendy, I'll turn it over to you for any questions.
Well, thank you so much, Dr. Rosenstein. That was a lot of great information, and I really appreciate you embedding some of those articles and those pieces of content. Those are great references for our audience, so thank you for that. At this time, we would like to allow for audience questions to be answered. There's quite a few in the Q&A box now, but if you still have a question, go ahead and enter that. We'll get through as many as we can in our time remaining. So, Dr. Rosenstein, this was one that came in midstream in the presentation. What do you think is the best overall approach for the busy physician to get them to understand the importance of emotional intelligence?
Yeah, that's pretty much covers the whole topic. As I said before, physicians a lot of them are frustrated, and they're changing models of care. A lot of physicians are becoming employed physicians. They're losing their autonomy and self-control, and they're having to adhere to either productivity metrics or patient outcome metrics. They're not in a good state of mind. So part of it is they need somebody to talk to. So the idea first is to just sit down with the physician and how are things going, and at least give an opportunity to get some of their stresses off their back and talk about some concerns that they have. And then the topic can revolve around our goal is to get best patient care. So you're reinforcing their goal, which is what they want, is best patient care. It's what everybody wants. And in order to do that, we're really here to help you. You are a very important asset to our organization. And one of the things we want to talk to you about is how we can better improve relationships with your staff, with your coworkers, with the patients and the family. And then we'll talk. Then you can get into the more didactic issues around emotional intelligence. Basically, the sentence is, one of the important things is to understand what the values and perceptions are of those individuals that you're dealing with. And it's all under the goal of best patient care. So it's just getting them to reflect on the importance of being sensitive to what's going through the mind of the other person, because if you understand what's going through their mind and what their values are and what they're looking for, then you'll be able to come up with a positive result and will avoid all the frustration and distraction.
Great advice. Starts with the reflection. Thank you for that. Next question is, as more and more physicians are being employed by hospitals, how has this changed things as far as managing disruptive behavior?
An interesting question. Well, now what happened is the individual, rather than being autonomous, when you're an autonomous physician, in theory at least, you're not accountable to anybody, and you can act the way you can, and it takes a lot to control you because you haven't signed on the dotted line. When you become an employee physician, then you're subject to all the protocols and processes and procedures of that organization. So there is much more of a consistent accountability because you're employed, and these are the doctrines of the organization. So because of that, when they start to unfold a little bit, it's easier to pull them in because they are now accountable. So because of that, and because of the fear now of if you're going to eventually get terminated if you continue to act out inappropriately, I think the incidences of disruptive behavior are a little bit less. And I think the enforcement of what needs to be done early on, because you're now an employee, is easier to do.
Well, I'm going to ask this next question because I think it's a nice tie-in. This one just came in. How to get leadership buy-in and support. So I think it stems from sort of the top-down embracing emotional intelligence for its staff.
Oh, but yeah, good. I mean, this is really the cultural discussion. Leadership, everybody needs to understand that it all comes down to relationships. I mean, you can have the best technology in the world. You could have the best guidelines in the world. You could have the best practicing physicians in the world based on quality metrics and competency. But in the very end, and this is particularly true now where satisfaction is becoming such an important point, it's now one of course, the HCAP's pay for performance incentives. The overall experience from the patient and also from the staff is crucial. And that really comes down to relationship management. So what I think what the leadership needs to do is to understand how important it is to have successful relationships. And, of course, good relationships is emotional intelligence, and it's the techniques of good communication and collaboration. They need to understand how important this is, one, for recruitment and retention, two is for overall morale, but three, and most importantly, if bottom line is what they're looking at, it improves efficiency, it reduces waste, it improves your metrics, and it lowers the liability of some adverse event for which you potentially have a financial penalty.
great answer. Thank you for that. In your findings and your research, where is the largest area for improvement in these communication channels? Physician to physician, physician to staff, within the staff, or all providers to patients and families? Although I'm sure benefit in all areas would be a good thing. But what one area that needs the most improvement that you've seen?
Interestingly enough, it's physician to physician in my feeling, because you have very strong egos with very, very siloed, and not that this is wrong, ways of approaching. I mean, an oncologist, all the oncologist is thinking about is, and I'm being a little bit tongue-in-cheek, so forgive me. I am an internist. So an oncologist is interested in killing that tumor cell. The surgeon is interested in cutting out that individual cancerous tissue. The infectious disease doctor is interested in making sure there's no secondary infection, and so on down the line. So what you have is you have very strong personalities who are so competent in their specific area of expertise that it's like they have blinders on. That's what they do, and they tend to lose perspective. Okay, is this the best thing, given everything else, is this the best thing to do for the patient? And is this the best thing to do from all of our individual disciplines combined? So the problem with the ego and the problem with their blinders type focused on what they need to do makes the physician-to-physician communication very difficult at times. And in the end, to me, it's the consistency of the treatment plan that takes in all perspectives that's the most crucial aspect. So when you're having physicians reluctant to talk to other physicians or reluctant to question another physician about what they're doing, that's the one that can have the greatest impact on overall patient care.
Thank you. I think this is probably a good time to ask this question, and I can respond to this. It ties a bit to your answer. This is particular to PerfectServe, but can PerfectServe send group messages? For example, if I have a patient receiving care from several different physicians, can I send group messages to those physicians or a care team regarding that patient? And I think this touches a little bit on what you just mentioned, Dr. Rosenstein, about physicians connecting with one another. The answer to that is yes. PerfectServe does allow physicians to send messages to groups and can even create and save custom groups for a team that might be working with a particular patient over time. So one way to shoot towards bridging that gap. A couple other questions. Maybe I'll answer or ask one more while we have about 2 minutes left. Your list of solutions is comprehensive. What do you think is the most important? I'll just jump back to your slide there where you have them listed.
Well, I don't see the slide, but I'll just recollect. Actually, the most important thing is culture. It's organizational culture. People need to get together to really understand what needs to be done to get patient care. Yes, it's a matter of finances. Yes, it's a matter of clinical expertise. Yes, it's a matter of appropriate staffing and resource utilization. But it really is important about relationship management and the attitudes of the people, because culture is the collective attitudes of the people. So in order to reinforce positive attitudes, positive morale, and foster positive relationships, that's what's going to lead to positive outcomes in patient care. That's the umbrella. So that is the most important. The obstacles, though, are getting everybody, one, to recognize how important this is. Two is to restructure what you're doing or invest more money to make it happen, because sometimes, particularly in CFOs, they're so focused on the short-term benefit they don't understand what a long-term benefit is. So you really need to get them to open up their minds, and it's not going to be a burden financially, it'll actually be an asset. So the cultural improvement, the willingness to change, and the willingness to change structure and add additional resources. Then providing this type of training, whether we just say emotional intelligence or diversity training, then having a program that all staff are able to participate in. But when you're dealing with physicians, and not that they're unique, you need to do it in the what's in it for me, make it convenient for them to do, and certainly to promote the advantages of what they will get out of this, which is they're happier, they're more productive, better patient care, less friction. So it takes a lot of time and effort to make sure all these individual pieces line up, but that's what needs to be done, and that's the crucial issue. So it really starts at the top, and then it sort of dribbles down, recognizing that different groups may have different requirements.
Well, thank you for that. And the comments coming in through the Q&A box definitely echo what you're saying. So we appreciate that. I know we had some questions we didn't get to. Dr. Rosenstein's email address is on the screen, as well as mine. You can reach out to either of us, and we'll make sure any remaining questions get answered. We've had a number of questions also about the recording and slides. The recording will be posted to the PerfectServe website in the next day or so, and you'll be getting an email from me with a direct link to that. So those of you that were seeking out the slides, will certainly get them to you. There's a poll on your screen right now, and if you are interested in learning more about PerfectServe, please let us know. We are proud to have sponsored today's event on emotional intelligence, and we will continue to share with you our calendar of upcoming webinar events. All of our previously conducted webinars are posted in the Knowledge Center on the PerfectServe website. And I also wanted to let you know that Dr. Rosenstein has a great website. It's listed there on the screen with a ton of great content on this topic and other areas, so feel free to check that out. One final remark before we conclude. When you registered for today's event, we did promise that one lucky attendee would be receiving a copy of the book, The Brain and Emotional Intelligence, New Insights. And before we conclude, I wanted to share that Michael Misko is our winner. Michael, we will be in touch with you soon to get that book into your hands. Dr. Rosenstein, thanks again for being our guest expert today and sharing this great content with us. And audience, thanks for joining us. Have a great afternoon.
Ladies and gentlemen, that does conclude today's presentation. We'd like to thank you once again for your time today, and you may now disconnect.